We're live.
Welcome everyone to this evening's Health and Wellbeing Community subgroup, and thank you all for giving up your time today, as I know it's an incredibly busy time for all of you. And just reflecting on essentially the changes that we've seen since our last meeting in November. We're now in a third lockdown, got the rapid mobilisation and rollout of asymptomatic tests and also the vaccines. So I'm conscious we have a lot to cover off today, so I'll press straight on. First, we have apologies for absence, and I think we have apologies from Dave Curtis and no one else. And then just moving on to declaration of pecuniary interest. Are there any declarations? No. And straight on to agenda item 3, minutes of the previous meeting. Were there any sort of queries, comments on the minutes from the 3rd of November meeting? I will take that as agreed. So the next item is COVID-19 update on testing and current restrictions, and Dagmar is going to lead on sharing and explaining those developments. Over to you, Dagmar.
Thanks, and good evening, everybody. So what we've got in terms of the slide set, my bit has sort of 2 main parts. One is that I would like to share a bit of updated epidemiology with you, just so that we all know where we are. And the second part is I wanted to spend a little bit of time on our asymptomatic testing, because there is very easily misunderstandings slipping in, and I think us as a health and wellbeing board really helpful if we really understand all the different nuances. So Chair, I don't know whether you want us to break after the data and take data questions, or whether you want me to rattle through and then take the questions together, whatever you prefer.
I think maybe if we take questions together, that would be good.
Okay, that's cool. So if you want to move me on, Clarissa. Clarissa, can you move me on?
Can you see that, Dagmar?
No, it's not moving. I can only see the
front
cover, the front slide.
Anybody else?
Can you all see the next slide?
No, we're just seeing the front slide, I think.
It's got stuck, I think.
It's funny, on my screen, I'm getting the correct slide.
Oops.
I've only got the front screen.
Yeah.
Louise, any ideas at all?
I'm only getting the front screen, so
right, I'll stop and I'll
start again. Yeah.
So if I start, the first, there you are, that's the second. So if you move me on, that's it. So the summary messages, they're all in red just to wake us all up. And as you're absolutely aware, since November when we last met, all the main indicators have gone, unfortunately, in the wrong direction. And just in terms of scale, so we are hovering about 1,000 per 100,000 over a week. That gives you about 300 a day. And in our earlier meetings, you will remember when we were really worried about sort of 2 figures, 3 up to 50, we would say that's really alarming. So the scale has completely blown out of proportion, and all of this is very much mirrored. Unfortunately, it means the over 60s rate is really high now. You will remember that we had a time when we had particular infections in the younger people. This has all bled all over all the age groups. And then unfortunately, but completely predictable, it now also translates into more deaths. So for the first time, we have 2-figure numbers as our weekly deaths. So 13 over the previous week, this week indeed 18. If you move us on, this is just more illustration, because we're obviously not in a bubble. We're part of London, and you will be sort of familiar with these slides now. we ran out of colours in a way. So it's purple is the worst, and I call it bruised. People know me by now. And Merton, indeed, on the infections per 100,000 is in the worst category. If you move us on. These shows you increases from 1 week to another. And again, we are pretty steep, particularly, as I said to you, we started relatively low in the over 60s, but it's rocketing up. If you move us on. And this is then the really important slide. If it would be just a light disease, it might be a nuisance, but it does translate into, for some of us, into serious disease. And that is then mirrored by what happens in the NHS and in hospitals. These are general hospital admissions, then admissions to ITU. On the left-hand bottom corner, you see quite dramatically what happens to bed occupancy, and that obviously chimes with what you've hopefully all need convincing around the NHS absolutely aching under the pressure. And then on the right hand side, it's the seriousness of the disease. So these are all patients that are either mechanically ventilated or on oxygen, or what we call CPAP. So we had a meeting with our acute providers earlier in the week, and she started to say it's grim. So from over the summer, really coping very well. Are you stuck again, Clarissa?
No, Dagmar, you went silent for a moment. I'll go on to the next.
Moving. Mine hasn't moved.
Has anyone else got the testing sites in Merton?
Yes.
Okay, now it's moved now. Sorry, mine was probably a bit laggy. Maybe my internet was a bit slow. So there are some analysis that I wanted to share with you as well from our more sort of local approach. One was very important, as we've said, and you've been helpful in promoting the message that if you have any symptoms, please test, and then self-isolate. Testing on its own does nothing, but testing and self-isolating is obviously the way to break transmissions. And we've worked very hard to get 2 local testing sites, one at Merton College, and I think one of you mentioned the Merton College site as well, and then one at Mitcham Elm Nursery. And you will see right at the left hand of the graph, only at the beginning of December, we had actually really quite low coverage. You know, the Elm Nursery started around sort of 50%, but Merton College was hovering sort of 30%. And then you see how it has rocketed up, mirroring the increase in infection, but also the responsiveness in a way of a number of people to actually get the test. And then over the Christmas holiday, we had very much pleaded with DHSC, and they responded. They increased capacity, opened, lengthened, extended the opening hours, and more within capacity again. So the message still very much stands that given all the asymptomatic testing, people mustn't get diverted, and if they have symptoms, they must go to the testing sites. They have to book it, but they're the local ones for the proper PCR test. If you move us on. Obviously, we're always looking at east and west. That is very important for us in Merton. So these are infection rates for east and west. And you will remember the graphs in the earlier days was sort of crossing, and sometimes it was the west, sometimes it was the east. More recently in this spike, the east seems to be ahead of the the West. So we keep a very close eye on where that is going, and obviously disparity of impact is one of the big themes that we want to protect as much as possible in our community. If you move us on. This one is a really helpful slide, what I mentioned before. We call it the heat map. So this is infections by age groups. And while sort of in October, September, October, we had quite a lot of colorings in the younger age groups, we now have basically the infection all over. Yeah, that's the sort of main message of this graph. If you move us on. And then very importantly, Rebecca, you were the one nudging us. So we are monitoring now the ethnicity of our of the infections that happen to Merton residents, and compare that with the right column, which shows us what is the distribution in the community, to see whether there are any disparities. And unfortunately, the latest data have quite a lot of missing, so that can distort. There were some signals earlier. You can see that we had some more Asian infections, but all in all, there aren't any completely stark signal. We're working again very closely with our NHS colleagues to have a little bit more granular data as well. Who is actually going to be admitted, who's ending up in ITU. And when we've got those data, I will share them with you. If you move us on. These are our outbreaks, and when we, I think, met in November, we were talking a lot about school outbreaks. Ellie, I think you were quite involved. Schools have been absolutely brilliant. They are now real allies, you know, doing their own risk assessment, contact tracing. It is really impressive. Now, obviously, with initially the school holiday and now the school closure, the situation in schools luckily has calmed down. Main outbreaks now are in care homes. Really quite explosive. That's how we also were suspicious, and then it confirmed about the new variant being more transmissible, because we are very much investigating outbreaks in care homes. We do audits, and we could not find real breaks or anything in infection control. Nevertheless, once you've got it in a care home, it goes very easily like a wildfire. The only consolating fact is that because we are doing regular testing, PCR testing as well as LFT testing, so really tight testing, we find a lot of asymptomatics. And if you think in terms of harm, we're obviously more worried about the symptomatic cases. So that is quite different to the first wave, where we had lots of symptomatic cases from care homes. But an outbreak is defined as any positive case in a care home. But you can imagine the numbers you see here, it keeps us pretty busy. And so in our care homes, and again, my hat off for the care home managers, it's a really testing time. If you move us on. And then this is the sort of tragic end of the COVID sort of outcome. It charts our deaths, and as I said, unfortunately, it is very predictable. If you have infection rates that we have had, with a bit of a lag, 2-3 weeks, you then see death climbing up, and that's the case for Merton. But in comparison to this nasty spike in April, at the moment, luckily, we are not quite at that scale. If you move us on. So that was just a canter through where we are. Before I talk a bit about asymptomatic COVID testing, I just wanted to share with you a slight more positive glimmer because, and obviously, you know, one day doesn't make a trend, and you have to hold that. But it was a lot more promising that it seems to hover in London, not shooting up that extremely anymore, and possibly even on the way down. So let's all just take a deep breath and hold on to some of those more positive signs. So asymptomatic testing, first of all, I just wanted to be very, very clear that we all understand what the purpose is, because it can get misunderstood. So the main thing is that we want to find people who are positive but don't know it. So they have no symptoms or very minimal symptoms, and they can transmit. We think 30 to 40% are probably asymptomatic. But the very, very important bit is that it only works to break transmission if people test and then find, oh, I'm positive. They're actually sticking it out to self-isolate. And guess what? The motivation, if you feel fine, to self-isolate is quite tricky. And so what the experience shows is that we have to support people with that. Because it is very tempting to break it. And actually going, if you're asymptomatic for a test, the psychology is that people go there because they want a negative test. It's a bit like screening. You don't go for screening because you want a positive. You want to be assured that you are negative. But that is not really what the purpose is. And so the psychology is a bit different. So there is a risk that people say, a positive, nah, I feel fine. A negative, hooray, now I can do, as if nothing is the matter. And neither of those are correct. Yeah, so test to find means if you are positive, you're positive, you have to self-isolate. And if you're negative, it really only tells you that you're probably okay for 24 hours. Yeah, so the only other way that we use the negative is the test to enable, and that requires 7 consecutive LFTs, so fast tests. And we use it, and Rebecca, you mentioned that we use the testing to get back to a bit more normality. If there is a central or key worker who has been identified as a close contact, and that person then tests seriously every day for 7 days negative, then each day they can be enabled to go back to work. But it's very important. People are quite jittery because, as some of you already discussed before, the fast tests aren't that good. So we are not yet allowed, in a way, it's not yet approved to be used for test to enable universally, only in pilots. Yeah, so that for us all, to understand these test to find, test to enable, really pretty pivotal in of the program. And then, just as a reminder, the 2 tests we can use for asymptomatic testing, there is the PCR that I think we discussed before. It's highly accurate, but it needs a laboratory. It needs a swab. They are both unpleasant because it's nose and throat swab. And then obviously the drawback is that it's a turnaround, and depending on how busy the labs are, it's 24 to 72 hours. But they are normally pretty good. Now, there's always exceptions, and we've heard about an exception, but generally, sensitivity and the specificity is really good. They're costly, and so therefore we only use them for asymptomatic testing in very high-risk settings like care homes. Yeah. Now, the test that has, in a way, innovated our asymptomatic testing is the lateral flow, and it's called an LFT, a lateral flow test, or an LFD, a lateral flow device. And that is a point of the laboratory. It's still an unpleasant thing, so nose and throat's the same. And then it's a bit like a pregnancy test within 20 to 30 minutes. It's a bit fiddly. You have to drop some reagent on there on the swab surface, but you have got the result there and then. But the drawback is that it's not that accurate. Yeah, and at the moment, as you've also heard, if it tests, you have to self-isolate, and then you have to do a confirmatory PCR test. And if it's negative, you can only really say okay for 24 hours, but not carte blanche. You have to continue to adhere to all the social isolation stuff. So, excuse me, that was just for us all to understand. Now I share with you very briefly what our model is and how we use the testing in Merton. So two things: we focus mainly on frontline staff, because we're obviously in lockdown, so everybody should stay at home, but there are some staff that actually has to go out to keep us all going, and they are taking risks and they are exposed. So it is only fair that we say we test them regularly. And the idea, the regime is normally once or twice a week. We are also offering an opportunity, if any resident in the borough wants a test, they can have it. But we are not pushing the type of mass testing that you've seen in Liverpool, because it isn't long-term that's sustainable or effective. And so there's quite a big and increasing national service tests. So secondary schools, universities, care homes are already receiving the LFT tests directly. And we've just got more news today. Police and fire service and other big organizations will receive the national, the LFTs nationally. But we will help, because it is quite an endeavor to set it up. We then have locally, and we are proud of that, and I have to put a big thank you to Barry, who pulled this off, our local community pharmacists. So they are dotted all over the borough, and that is a bit more long term, and we hope that they engage or have the ability to engage with the people. They come to them in a bit more of a longer term relationship. We then have got the devolved LFT staff testing. What we mean by that is that teams in the council, as well as in partner organisations that are not covered by the national model, we can help them. We supply them with the tests and the training. We manage the testing. A site-based testing centre, and again it has the double purpose. We're particularly using it for frontline staff that isn't covered otherwise, also open to resident testing. And obviously what everybody is asking, and you will ask, is, oh, wouldn't it be fun if we could do it from home? Absolutely. Unfortunately, the in principle approval has happened. You know, there is a regulatory agency in this country, but not yet for home use generally. But that is something that we are absolutely lobbying, because we think we can again revolutionize, particularly the regular frontline staff testing, if they can do it from home. If you move us on. And I'm aware of time, so I speed up. Yes, but for you as the reference, I've given you a little bit more flesh on the bone for the community pharmacists. We're particularly targeting volunteers, carers, and we also not have only got where people just do this, have what we call an enhanced option, so that the community pharmacist can actually explain, do some health protection work, but also some health promotion work, because we do know that people are more at risk of COVID when they have, unhealthy lifestyles, etc. And for the future, we plan with the community pharmacists to work on the test to enable, as I explained. So if we move us on. The devolved model, as I said, it's police, fire, primary schools, early years in particular. I think Ellie will be interested. And so the team's organizations manage the testing, but we help them. And we get the tests and the Department of Health. If you move us on. And then Modern Assembly Hall, I think you're all aware, the team was actually really pulling the stops out. So it was launched 4th of January. You can imagine what the Christmas holiday looked like. It's staffed by volunteers, but really passionate volunteers. We had to start slowish so that it's a safe place, but there's capacity to now really increase the slots. I think that's it. So I think I probably stop here. The next slides are around the restrictions and also the incident that the mayor has declared, but I suggest they are for your reference. And I'm open for questions.
Thank you very much, Dagmar. A very helpful update. And I think, as you say, a grim position, but then positive signals around the access to testing in the borough. So could I open for questions? Anyone have any questions for Dagmar, either on the sort of situational picture or on the testing? Ellie.
Thanks very much, Chair, and thank you, Dagmar. I was going to ask about earlier settings, but you covered that. So my question's actually more broad about what the message is to residents about the use of the asymptomatic testing. And I know it's all new, but we've had some feedback about people booking into the Morden LFT site and then having issues that they weren't there. And in your presentation there, I think it said something around, for Merton residents, it should be seen as a kind of one-off. So what is the message? Is it like, if you are providing a volunteer service, you should do it just before then, or let's be clear.
Yeah, so you're right, and because things change all the time, by the time you've done the comms, it has changed again. So any help, because you are on the receiving end as well, and you are interacting with people who are on the receiving end, is really, we really welcome the feedback. So the main message is that we want to focus on what we call targeted testing, and the main target are frontline workers that still are exposed to daily contacts with other people, because the principle is infection is transmitted by contact, particularly between different households. So any worker that has to go out, maybe travel, and is in contact with others, we absolutely suggest please test. Because the Department of Health in particular had a bee in their bonnet, that they said every resident, if they so wish, could have a test. The Morden Hall Assembly Hall is open. So if a resident insists they want a test, we wouldn't say, oh, you're eligible. Yeah, but it is not the bit that I'm pushing. And what we particularly say now, as we are in lockdown, please don't travel for a test. There is pain versus gain is just not justified. And please stay at home if you're shielding. Do not go into a testing center for an asymptomatic test. Whereas if you are shielding and you are symptomatic, order a home test PCR. Yeah, that's a sort of messaging. But do feedback, because the landing of this is, you're absolutely right, is quite nuanced and easily misunderstood.
Ellie, do you want to go back on that?
If I'm allowed, then a quick follow-up. Thank you, Dagmar. Yeah, because we all got, as Merton residents, we all got that letter saying this test centre is open to you. So I was like, should I be encouraging people to go to it? And that I understand you can book on the merton.gov.uk website, and I've heard of people using it really appropriately for, like I say, if they are about to volunteer, they just want a confirmatory test. And that sounds to me very sensible. I'm a bit unclear about the community pharmacy's role. So you said there are 10 now open. How do people book those? And would it be preferable, like you say, that they wouldn't travel to Morden, but instead go to their pharmacy? How would they find out about that?
So you're absolutely right. So the model is not just very neat categories that all not overlap. So there is some overlap. As I said, we've coughed this up between Christmas and so what we say is, again, the pharmacists also target in frontline workers, but we're particularly saying the voluntary sector. We were very keen that we have in the voluntary sector covered, and we were very keen in particular to cover carers, and not just the ones that have some type of certificate that they're a carer, but the informal carers as well. So it's very much driven by the individuals themselves. And because, again, we say if you're a carer, for example, we would really suggest that you regularly test. The community pharmacist is part of the community. There might be a bit of a relationship building. And with the enhanced service, there is then the opportunity for the carer to community pharmacist as more than just a sort of mass production, like a site that just gets the swab done, to give you a little bit more support, and that's the enhanced service.
Thank you, Dagmar. Okay. Rob, question.
Thanks, Dagmar. Fascinating as ever, and very helpful. Just picking up on the asymptomatic testing, and you talked about people's behaviour around asymptomatic testing. And I'm very pleased that kind of the voluntary sector is being very much included in that programme. I think that's a really good and wise move. What advice would you give us in terms of simple, clear messaging to our teams to encourage and ensure that people are asymptomatically testing, and if they get this result, or if they get this result, how do we make sure that they then absolutely do what they should do? Is there any particular key fundamental drivers around behaviour that you would like us to consider? Because I'm kind of weighing it up in my brain.
Yeah. So one important message is that if you start, even if you're a small business, if you're a larger business, if you start to regularly test your staff, you will find some positives. And if you then, you have to therefore pre-plan a little bit in terms of your service continuity, and really plan, can I stick it out? Because if you started and then you think, oh my God, I wish I hadn't tested, then I could continue type thing, that is not where you want to go. Yeah. So what we often say, the warning, you will dip. You might dip a bit in terms of your service continuity, particularly the first round, but then you come out of it. If you don't know that you have asymptomatic positives, they are spreading it happily. And the likelihood is that you then get symptomatic positives and you have an outbreak on your hands. So ultimately you are better off, but there is that initial bit where you have to psychologically prepare yourself. Yeah, so that's one of the sort of key learnings.
Thank you, Dagmar. Mohan.
Thank you, Rebecca. Thank you, Dagmar. Really good in terms of seeing that data, and you've made it sound so eloquent, actually, that it's not so severe, but it is. And I just had a couple of questions I wanted to ask. Slide 10, where you talk about the numbers and age range, and it stops at over 60. Do you think there's any chance of getting it for over between 60 and 80 and over 80? It'd be nice to see whether the over 80s rate starts to come down as a result of the vaccination. I don't know whether that's possible.
Yeah, I think it's a really good question, because we've already pushed and said that's where we want the impact of the vaccination to start to bite. And if we are actually delivering in priority group 1 to 4, then by the middle of February, we should have covered the 8+80s and the mortality should drop. So we are pushing up the food chain that we get the result.
Excellent. Thank you. And with the lateral flow testing, certainly is interesting. The volunteers who've been working out in the vaccination hub, they actually proactively wanted to have the testing because obviously they're going to be in contact with a lot of vulnerable patients, and so we've sort of set that process in place. But out of the 12 which we tested first of all at the start of the vaccination hub days, one of them was positive, so one of them had to go home and so forth. So it really does, like you say, pick up sort of the asymptomatics. But I think it'd be quite keen for them to use this service as well. Certainly they want to do their shift. They want to do their test before they come on shift rather than coming in and doing it in the corner. So I think that'd be really, really useful. And one last observation is the actual testing itself. So I think you mentioned that to do the nostrils and the back of the tonsils, whereas the Health Education England and HSE just go for the nostril one. So it was just an observation I found. But yeah, thank you.
Vasa, sorry, did you want to raise a point? Oh, Vasa, I think you're muted.
Thank you, Rebecca. Well spotted. I'm not as technically advanced as Mohanesh. Question for Dagmar. In the last time round, we knew that people from the Black and ethnic minority communities, apart from over 70s, they were the next who sadly suffered the most. I don't see any reason why that's going to change, sadly, this time round too. Knowing that, how are we specifically getting the message across? Because this time round, it may be 50 to 60-year-old people from the same community who may actually suffer the most. And I think, though we don't have the evidence to say that, I think we can have a clinical suspicion to say that, looking at early admission picture, early ITU data. So how are we going to get it across to the community, especially that community, that the issue about the viral load, the ventilation, keeping the window open, strict household type of stuff? Because it's sad, because you and I know the theory, but that's no good saying in our heads.
I think, Vasa, if I may, that is precisely the challenge for us as a group. Not just on my lap, that's why we're here. And I think, to be fair, the community champions have exactly tried to do this. And primary care and your colleagues have exactly tried. But you are right that we need to then see how have we succeeded in this. And for me, the challenge going forward is continue with the protection measures, but also think about the next challenge, which is the vaccine hesitancy in certain groups, often coalescing with those who are most at risk, and what can we do as a subgroup to possibly help there.
Absolutely, that's a tragedy. The group which has got the greatest number of vaccine hesitancy and vaccine doubt is also sadly the same group which is falling. And I think we got to do whatever we can to try and get into that space, because I think otherwise we're all complicit, if you don't mind that word.
Abby, did you have a question?
Thanks, Chair. So I just wanted to clarify something, actually. So I know that we talked about the targeted approach to testing in Merton, and the headline for that is frontline staff. Within that, are we kind of talking public sector staff there? Or are we also thinking about the kind of people that were at risk previously? So talking about security guards, kind of retail staff, bus drivers, that sort of thing. I'm just thinking about the question posed earlier about kind of, if you can only get one test and your employer is not providing that because they're not kind of, in the national scheme, how are we kind of looking after or catering to those residents?
So you're precisely spot on, that anybody who is exposed, and for us in particular, thinking about those who are most vulnerable and exposed with the least agency to actually say, I need to socially distance, are the ones that we want to offer the test. So if you are a worker in Merton, you can turn up in the assembly hall if your employer doesn't provide it. But the new guidance that has just literally this afternoon come is that the national programme will cover that. And so TfL, for example, but we are also asked to engage with not only public sector, but private sector employers. So absolutely. And what we, for example, have done for London Borough of Merton staff, it's obviously the directly employed staff, but we also commission quite a number of staff, high-risk staff, waste people, for example, in providing the waste service. And so we have explicitly said it's open up to them.
Thank you, Dagmar. Martin.
Hi there. I'm just thinking, like, we done an engagement session, and we found that we had 2 people that had family members that were key workers. And after we started explaining about testing, they actually felt like actually they could be at risk. So you got to think, like, the people that are key workers that are going out, and obviously they are at risk of getting the virus. It's kind of like it's their families as well that are at risk of getting it at home. And if they don't know and they're asymptomatic, they could go shopping and then they might not know they have it. So I was just kind of pointing out that that's something that came out of our engagement that I think is quite important, that even though you're saying, you know, it is for a certain group, it is also for their families. So, yeah. Well, it should be, yeah.
It's really helpful. Thank you, Martin. I think something that's come up through most of these questions really is around the need for very clear messaging. I know that obviously the situation is changing really rapidly, but maybe there's a role for us in terms of sort of crafting that messaging and also looking at the engagement side of things as well, which I think we can pick up outside of this meeting as well. Did anyone else have any final questions before we move on to vaccinations? Okay, could I ask one really quick one, Dagmar? I know there's been a huge amount of work to really rapidly mobilise the community pharmacies in terms of testing. I think we've discussed previously there being sort of a bit more of a challenge, I suppose, in the East in terms of ensuring access there. And I just wondered whether there's anything that can be done, I suppose, in terms of improving that access or mobilising in the East.
Yeah, so first of all, delighted. And again, I hand over to Barry in a minute. His charm attack it did bear some fruit. So on the 13th, the MENA one is opening, but I think there's another one on Pollard's Hill now on the books. So Barry, is there anything else that the group could help you to get the spread of the community pharmacies as widely as possible and as evenly in the East?
Thank you, Dagmar. At this stage, I don't think there is anything that the group can do. We're working through the local pharmaceutical committee with all of the pharmacies across the borough. So we've got 10 currently up and running. There's a community pharmacy in Mitcham opening from tomorrow. There's another community pharmacy opening up in Pollard's Hill on Thursday. And most of the other pharmacies have all expressed an interest. They're really keen to be able to support this really important program. They're kind of working through the training and the risk assessments and how they can deliver the program safely and effectively. So I don't think there's anything right now, but I certainly know who to come to if I need any support, if that's okay, Councillor.
Thank you, Barry. And I think just last question from Una before we move on.
Sorry, I just realised I'm muting. Yeah, no, thank you. And I think it's been a terrific programme. I mean, I said earlier I took part in the asymptomatic one because of outbreak in our family. But just to say that when it comes to community pharmacies, and I do have a son who is out in the front line as a carer, and I know he's getting sort of PCR tests, which is what picked up something on his front. With the community pharmacies, I gather they can go to those, but how do we know which ones, and do they have to be booked in advance, a bit like the asymptomatic tests that we did? But you know, you mentioned there's 10. I just wondered if is that in the public domain or not?
Thank you, Una. So the booking of the community pharmacy test is exactly the same portal. So you go to one place, one website, and depending on whether you are a frontline worker or a resident or a voluntary sector member of staff or volunteer, it will signpost you to the appropriate setting. So there's one place to go. We made it as easy as we possibly can for people to book those sites. So when you go to that booking portal, it will show you the nearby community pharmacies or the Morden Assembly Hall venue, which has available booking slots. So we've tried to make it as simple as possible for people to access those sites.
And the different community pharmacies, where do we find out who they are? Or are they just on the website?
Yeah, they are on the website, and they're all in the public domain, so happy to share that information. But the best place to do, if you want to book an LFT fast asymptomatic, is to go to the web portal, book those slots, and that will show you the available community pharmacy slots for you to book a slot.
Thanks.
Thank you, Barry, and thank you, Dagmar, for your presentation and for responding to those questions. So just as we move on to an update on the COVID-19 vaccination, so I'll hand over to Mark and Vasa, who I believe will be presenting on this.
Hi, yeah, so I'll present, and then I'll let Vasa and Mohan come in from a clinical point of view. So just to start off with saying just what a fantastic job our primary care colleagues are doing, because if we go back a couple of months, actually the plan wasn't to include primary care in the vaccination programme, but now they are the cornerstone of the programme. So it was just to start with a congratulations to our and a thanks to our primary care colleagues. In Merton, we're prioritising our over 80s and our care home residents and staff. We have a hospital hub at St George's, and we have 2 sites across Merton who are doing community and primary care vaccinations. We are not widely publicising those sites because we have people who are turning up to sites expecting to be vaccinated. So we really need to, for us all, to kind of share that message. You will be contacted and invited in when you get on the priority list, and we work through that priority list. So it's really important, as well as the hospital sites in the community. Across Southwest London, we are also looking at larger sites for kind of more mass vaccinations as well, and they'll be coming online very shortly. With the priorities, we are working to the top priorities being vaccinated by mid-February, which is a challenging time frame, and we are working flat out to try and achieve that. But we are expecting our over 80s to be kind of vaccinated towards the end of January, really. Obviously, that won't be, there will be some people that go into February. It is a national data set, and everyone is really, really keen to get the data, not least our public health colleagues who want to analyse it and tell us where there are gaps, etc. But it's a national data capture. So once we've got the data, we will share it with our stakeholders and with our colleagues. So we'll share it as soon as we've got it. It's really key that we get the message to people that we will know when, we will let you know when to come in. And just to make sure that and assure colleagues around the table that there is no wastage. We have processes in place that if anyone doesn't turn up for a vaccination, there is a process in place to target that to the other the same priority groups, but also involving care home staff as well. That is really key, that when we do contact people, again, they don't share those contacts out with social media. We have had cases very recently where masses of people have turned up at a vaccination site, and that really has caused quite a lot of problems in our just in terms of the functioning of that vaccination site. Care homes, we're reaching out to care home staff, and with the new vaccine, the Oxford AstraZeneca vaccine, that now allows us to be much more mobile. It transports more easily, so we will be targeting and getting into the care homes as well as housebound patients as well, and we've started to receive that vaccine. We're not having problems with vaccine. I think there's some rumors out there that the vaccines are coming to us as planned, but we are seeing more vaccines coming to us over the next few weeks. So again, the activity will really ramp up. We have done quite a lot of communication and engagement, particularly with kind of hard to reach communities, faith leaders, etc., to try and build trust in the vaccine, but also to listen to how what barriers might be in terms of particular communities accessing the vaccine. And we take that back, and that goes back into our communications team, whether it be a comms or whether it be something that we need to address. We are also looking at sorry, I have a 4-year-old who's trying to interrupt me. We also do have, as well as the kind of trying to address the take-up, we are looking at publicising information in different languages, Braille, etc., to make sure that we are targeting the most vulnerable communities. So I'll probably stop there, and Vasa, Mohan, is there anything that you want to add from a kind of clinician's perspective?
I think from a clinician's perspective, I think first of all, we must really thank the people of Merton, even when they turn up out of sheer desire, sheer desperation that they want to have it. And we very politely tell them, no, it's not your turn today. They humbly walk away. You can see their tears in their eyes. You can feel their pain in their heart. But they were very polite when they were turned away. And I think we really need to say it out loud that it was a peaceful crowd which gathered. And I totally understand why they gathered, because as much as in one group there's hesitancy in the heart, in another group there's desperation in their heart. And I think we need to respect that. And we need to do all what we can to ramp this up and really get this going at speed, because I think there is more scope for us. We can actually do more. Mohan, you can come in and thank your merry band of volunteers who I see in action in the freezing cold out there. I'm happily staying inside the building at the Wilson. For those guys, they are out there in the cold, right at the front of the car park. Over to you, Mohan.
Yeah, I mean, just to add to that, so, you know, Merton's in a very, very good place. 6,000 patients have been vaccinated, which is a great start. My mother lives in Kingston and they've not started the vaccination. It's not a competition, but it just shows that actually we're really good. We're getting some real vulnerable patients vaccinated. I also think seeing the Wilson alive again is great. It's great seeing, you know, that throughput, and actually it's a perfect place to get lots of numbers through, and actually a massive resource which is great to see in full flight. I think what's been really humbling, I've been leading on coordinating the volunteers. And it's been great work with Merton Mutual Aid, getting 46 volunteers, and as Vasa said, marshalling the actual hub and actually also calling and recalling patients as well. It's been absolutely humbling and really a great need as well. And they're there day in, day out, even in the cold weather. And I think that aligned with the mass vaccination sites, I think we're in, you know, Touchwood in as good a place as any other borough could be. So, you know, fingers crossed, and yeah, looking good. Thank you.
Thank you very much, Mark, Vasa and Mohan, for a very uplifting update on the vaccinations. Do we have any questions on the rollout? Una.
Thank you for that. I think that's really helpful. I think you did say that we were on track, Mark, but I just wanted to double check that obviously the government's put out this date of 15th of February, and so it would just be interesting. I mean, it sounds as if we've got off to a really good start, but whether we feel we can make that and whether that's a realistic target. And then my other question was around the care homes, and I'm just aware that well, obviously there have been some outbreaks in care homes, but also it would just be really reassuring, I think, to know that the rollout is happening well through the care home community. I know there has been a little bit of angst there. That's all. Thank you.
So I think in terms of mid-February, I think as Mohan and Vasa mentioned, the more vaccines we get, the more we can get through the system. And we are seeing a kind of like more vaccines coming into not just Merton, but Southwest London. So as soon as we get them, we are vaccinating. So I think it's good to be ambitious. Have I frozen on you? Or am I still with you? I think care homes, we have been reaching out to care home staff to come into the vaccination sites across Merton. I think with the new vaccine, the Oxford vaccine, that does allow us much more flexibility in terms of going into the care homes as well. And I know that our GP colleagues have been in contact with care homes to book appointments and to go in there. So yes, I think people have shared your concern about care homes. I think the Oxford vaccine absolutely allows us to be much more transportable, if that's a word, and get in there.
Rob.
To that, just quite a specific question about physical barriers to access. Some of the feedback that we're getting via the Community Response Hub is around challenges to actually get to the Wilson and those sorts of things. And it was a query that was raised at the Community Response Steering Hub today around transport and whether there's provisions in place for residents who are perhaps housebound, who have priority group but actually can't get their vaccine, and whether there's a plan to either help them to get there or to go out to them. It would be good to know if there are plans.
Vass, are you going to come in on that?
Yes. Yes, if you are housebound, then thanks to the Astra product, practices will be starting their housebound to deal with that. And I think that is the answer. That is the more realistic and more practical answer to deal with people who are housebound.
Great, thank you.
I'm sorry, I was struggling to unmute there. So just to repeat what Vasa says, if you're housebound, we will come to you.
Great, thank you for that confirmation. Ellie.
Thank you very much. And yeah, we'd heard about some messy situations at the vaccination sites earlier this week. And so it's good to have you explain some of those difficulties and be really clear about the message being only turning up if you've got an appointment. On the other hand, I've heard elsewhere about, because the Pfizer-BioNTech needs to be distributed and used in such a short time, have we done anything looking at if there are no-shows, if there's any way that we can quickly, rapidly really distribute that to other members of staff?
That's what causes the problem. So if you've got 50 left, we send text out to people to saying, okay, we got 50 left, don't let it go waste, come if you can. But the problem is we hope 100 people read it and half turn up. What happens is that is like water in an oasis desert. So that gets shared to I wouldn't say Tom, Dick and Harry, I won't be that insulting. That gets shared to every other person in London who is desperate, and they all turn up and they show us this email. And I read it out in the car park, and I really feel sorry because they genuinely thought they came to stop waste. They didn't come demanding for an extra bonus. So we really need to be clear. The public respond to prevent waste, but also out of the desperation. But that made our car park overflow. That made a few more than the number we wanted to cater for at the Wilson. But you know what? Wilson is a big estate. So we just opened up the other rooms which were not being used, and they moved everybody into warm areas. They were freezing for a while, yes, but we could quickly move them into some warm areas. But we have to accept that because we want to go for a zero waste policy, when we come to a point and we say, yeah, at 3 o'clock, we've got to finish this 50, then we'll be once again sending messages out there to get the right people in, but the right people will share it with others. So I fear that this is likely to happen till the desperation level decreases and the coverage increases. But I think with Astra, I think we'll have more freedom to actually cover more people and reduce that public desperation level down and get more staff immunized. Currently, the number of unimmunized healthcare workers out in the community or in hospitals or in practices or in care homes, the number of healthcare workers who are unimmunized is so high that is part of this desire. And I really feel for them because we asked them to go out every day since March, not yesterday, since March, we asked them to go out to bat for England. So when they turn up with an appointment, please, I don't want any one of them to be seen in a wrong light. I really want those who turn up with an appointment to be seen as entitled people who just haven't, the turn hasn't come. We mustn't make any wrong comments about those people who turned up on Saturday night. And I really am very passionate about that message going out too.
But and adding to that, just to say, we have learned as well to just, when we are sending the message out, asking people not to share it, because actually I think that's probably, it started a bit of a kind of domino effect, and actually we had targeted a particular cohort of care home staff. So we learn as we go along. I think that, this is all relatively new for people, but yes, we will target.
Yeah. Sorry, Chair. You know what? That Wilson site operates without a single security guard. All you have is clinicians who immunize and volunteers. And that tells you what England is all about.
Yeah, I'm just going to add. So I think the predicament comes sort of twilight shift, and just as you're about to finish the clinic, and you've got jabs left over. I was there on Thursday night, and you could hear a pin drop, and it was very, very quiet. And then the next day, it was the opposite. And I think we're now coming up with ideas to make sure that we channel the correct list so that we utilise all the jabs. It's better in someone's arm than in the bin, and certainly with all what's going on. So there are processes we've learned from that, as Mark was saying, to hopefully be a lot more streamlined.
Thank you, Mohan. And Abby.
Thanks, Chair. Sorry, I thought someone else was speaking just then. Oh, okay. So my question is about kind of how do patients find out from their GP, again, only the ones that are being contacted at the moment, how do they find out whether they should have the vaccine, whether there are risks for them, that sort of thing? I just wondered what the process for that is at the moment, please.
So each practice has a responsibility to go through their cohorts. So over 80s, if you've done the over 80s, over 75. So each practice books the patient in by talking to the patient. And before they get to the booking process, there are clinicians who are going through the list, checking for, are you on warfarin? Are you on this or that? And they make sure that the person is eligible before they make that phone call. But it's a very labor-intensive process. It does take time. Remember, we are talking to people with maybe cognitive impairment, maybe hearing impairment. So it's not as ringing my average patient for a sore throat. It's taking time, but they are doing it. But as we go down the list, it'll get faster. And with Astra, it'll get faster. So that is why I'm confident that this is going to get ramped up very fast. Mohan, anything I missed?
Yeah, I was just going to add. So I think the first criteria is over 80s, and I think once you've used that list up, you'd go into the second criteria, which is over 75. So you might see some areas having 75 and some areas still doing the 80s. What's good in general practice is that a lot of our resources are being redeployed to support the vaccination rollout and calling patients up. So our social prescribers are doing that role, health and wellbeing coaches are doing that, care coordinators. Everyone is on the phones ringing patients, either helping patients who are unwell with COVID or helping get patients get booked in for vaccinations. They're our two kind of aims at the moment. And I think once we get over this sort of bit at the moment, hopefully we can then start concentrating on other bits. But yeah, I think there's plenty of resource going in, contacting these patients, lots of questions about whether they should, whether they shouldn't, and they can come back to it. The vaccine rollout's going to be around for the next few months, so there's no rush, but a lot of people are jumping on board.
To be honest, councillors, you may get some feedback. Sometimes we have cancelled due to lack of supply issues, and that really hurts people. You tell them there's a date, and you ring and say that's being postponed, and I can understand that generates a bit of anger, bit of anxiety, and that is also true. And we have to accept that if you don't have a supply, then we can't honour our commitment, and we try and book them back in again. So, but these are all teething trouble. But once the supply gets more and more guaranteed, then I'm confident that we won't have the cancellation issue.
Were there any other questions on the vaccine? Apology, there's feedback in the background. You'll hear someone else on another call. But are there any other questions? Ellie.
If I may go again, if that's all right. And I've got two quick questions. So one of them is explicitly for Mohan about volunteers. Do you need further volunteers? Because that's definitely something that we as a board and through our networks can help you with. That's hopefully an easy question. Trickier question is back to that prioritisation list. And what influence do we locally have in where, for example, certain workers go on that list? You'll be unsurprised to know that the type of people asking me about this are teachers and early years staff, for example.
I think Rebecca.
I can answer the easy question, and then Dagmar's got a hand up for the other one. So the easy one, volunteers, we've got about 46 on the books, and they're kind of working quite well at the moment. I think we will need some. Certainly, this is a marathon, isn't it, not a sprint. So I will be in touch. Certainly, if we need more, because we kind of need to get their DBS done, and then need to give them a call. So there's a bit of work involved. But yeah, definitely. Thank you, Eleanor. Over to Dagmar.
So I think, Ellie, it's a really important question because I've been with the head teachers as well. And to be honest, I got a bit swept up in the unloved feeling of the head teachers as they don't find themselves in the priority groups. So I got back and actually read this stuff. What is the basis of the priority groups? And I've got it now. So the Joint Committee on Vaccination and Immunization have set the priorities. And there was obviously quite a debate. What should the criteria be? And there was relatively quickly quite a clear consensus that for the first wave, and there are 2 vaccination waves, for the first wave, the number 1 priority is maximizing mortality reduction. That's it. Nothing else, not service continuity, not anything else. How do I reduce mortality? That's quite handy to know. And so the first wave, priority group 1 to 9, are based purely on mortality reduction. So hear me out. If we have vaccinated group 1 to 4, we are expecting the mortality to reduce by 66%. And if we have vaccinated 1 to 9, which we're hoping by April, May maybe, then we are predicting to have reduced the mortality by 80%. I think once I've heard those figures, I said, I can buy into that. That's the wave 1. Wave 2 is different then, because we've now done the mortality, basically. So wave 2 will require more debate, because other criteria will come in. And what I therefore say to the teachers as well is, if you are at a personal risk, either because of your age or because of an underlying health condition, you will be swept up in the 1 to 9. But if you are not, simply because of your profession, that doesn't come in as a criterion in wave 1. And once you unpack it like that, I have found people can understand it a bit better. And for me, it brought a lot more a sort of clarity to the debate, but it's a lot of mixed messages. The other important message is that health and care staff are obviously the priority, a very high priority, and that is because of their exposure, their constant exposure. So when we look at the mortality figures, they have taken one of the biggest hits in terms of mortality, these 2 groups. And we are not we, the JCVI, are relatively generous in what they call social care workers. So I think our voluntary sector colleagues will have seen letters that, for example, services that deal with frontline homeless people, my drugs and alcohol services, they are similarly treated to health and care workers because they're basically doing the same. They're just not provided by the NHS, but by the voluntary sector. So it is not that we are stickling, but the main aim is the mortality reduction. That it made sense to me, to be honest, when I looked at it.
Thank you, Dagmar. Do we have any final questions before we move on to the next section? I'm mindful of time and slightly overrunning on the agenda. No, thank you very much to Mark Vassar and Mohan for presenting back on that really helpful update on vaccinations. I think I'm now handing over to Kaz and to Martin on community engagement, just an update on the ongoing programme of work.
Mark's suggestion.
Great. Yes, thank you very much. I'll start, but I'm delighted to have Martin on the line to talk about the engagement we've been doing with children and young people. So if we can move on to the next slide, please. So what I would like to do is really just update the group on what we've been doing to date. Particularly, I'd like to take the opportunity to highlight our partnership with the public health team, and particularly with our colleagues Amanda Roberts in the community engagement group. So that's been really useful as a place where we can continuously review the engagement that we're doing, along with some partners within the voluntary sector as well, and just think about, are we talking to the right people? Do we have the right reach? The values upon which the work we're doing has been based on has really been grounded in that partnership, but also in listening to and working with local communities and making sure that we are really benefiting from the existing capacity and resources that local organizations and indeed people in our communities have. That's been really wonderful, because what it's been able to do is expand our reach and make sure that the core messages we have around staying safe, around vaccinations are getting to where they need to go. We know that there is more to do. We know that COVID is impacting some communities more than others, and some of the work we've been able to do is really to look at how we can work with local leaders, informally or formal leaders, to make sure that we can set up the kinds of conversation that meet the needs of the folks that they serve. Some other work we've been doing, as alluded to earlier, was around young people as a seldom heard group, as well as some of the work with Merton Giving. So we've 4 grants so far. Okay, next slide, please. So I want to talk again just about some of that work with our minority ethnic communities. So the one I'd like to really highlight is work with BAME Voice, and they were commissioned by the local authority to understand the lived experience of people within our minority ethnic communities. This is fantastic work. They I think particularly really useful to point to the ways in which they have supported people as peer researchers to do this work within their communities and to articulate their findings. So there's been an interim report. You can see it here on the slide, but just to highlight the real psychological impact of being a frontline worker or of having a multi-generational household. It's really highlighted, I think, some of the physical space challenges that we saw highlighted during the first wave of the pandemic. There have been obviously some positive impacts as well in terms of time with family. I think that also worth highlighting is how the disproportionate impact of things such as no recourse to public funds during a time in which people's lives and livelihoods were, from a financial perspective, were very challenged. In terms of some of the interim reports, recommendations for areas for actions around that on-street engagement, but also how we can provide some support in terms of resilience for health and care workers from minority ethnic backgrounds, as well as better access to testing and access to health and wellbeing services. So they will continue to develop this report, and the final report is due in the end of February 2020. Okay, I think at this point I can probably hand over. No, one more. So we have also been doing some work with the Eastern European community. So what's, I think, really I want to point to here is the ways in which the term BAME, which we often use, actually covers a wide variety of different communities with different histories and stories. And with folks who would describe themselves as Polish or from Eastern European communities, there has been a feeling that when we've been focusing on minority ethnic communities, that their voice has not necessarily been as included as others. So with Barry, we had a workshop on the 5th of January to begin to build that relationship and understand what it is that we can do. Just to highlight here, the impacts of the community similarly to that unearthed by BAME Voice. So many people in terms of their jobs would have been disproportionately impacted by some of the financial challenges as a result of COVID, but also in terms of the language barriers they would have presented barriers to accessing NHS services, but also in terms of the ways in which services would have been used. Say in Poland, it does affect the ways in which people would access support here as well. The Polish community, I think, has been really supported very well by the Polish Family Association, and that's been a really great first point of contact for people. What we are going to do as a next step is really to follow up off the back of that meeting, to think about the ways in which it's not just a one-off. We can continuously make sure that we are helping the community to feel included when we look at some of the disproportionate impacts on our Black and Asian and other minority ethnic communities. Okay, I think this is the point at which I can hand over to Martin on our children and young people's engagement.
Thank you, Kalu. Yeah, so the young inspectors have been involved and working with public health and Merton CCG as well. And what we've been doing is kind of doing priority messaging and content production and digital media content for like Merton's COVID-19 response. And essentially what we're trying to do is get that same information that public health is providing, but we want to translate it in a way where young people will be able to understand it. And that doesn't necessarily mean like you're making that you're making many changes. It's just sometimes graphics are quite effective. Yeah, and so we've been doing 2 projects. So our first one is the Young Adult COVID-19 Community Champions, and that launched on the 16th of December. And we've also run a second session as well at the beginning of this year. And we've had about 14 and 16 attendees participated. And the meetings happen every 2 to 3 weeks. And then we've also got an under 18 COVID-19 champions, and that one is not officially launched. We're developing that. And that's kind of subject to the reopening of schools. But also we want to kind of be able to engage with, have kind of a lot of information so that we can also send it to parents. And yeah, the main reason for this is just to empower young residents to share the information with their family, friends, and neighbors. Is it okay to go to the next slide, please? So this is kind of we've got a live scriber who's been helping us do our graphics. So I think that's been quite helpful. But what I was gonna say is that the main thing is to understand the impact of COVID-19 on younger residents, and also to develop adequate support and to address misinformation. So that's kind of our main aims. The other thing is the main ways that we've been working right now is with Zoom workshops. We started kind of collating a mailing list of people that we want to send information to, and also using Eventbrite. Our next steps are to grow on WhatsApp so that we can send messages out, and obviously people can then also forward that on to their friends. And we want to also grow on social media to be able to have more, just a wider reach. And we want to create a resource bank that we want to share through a web page. Yeah, we can go to the next slide. In terms of our first session, sorry. Yeah, so we kind of wanted to know what was the impacts, and we, so just gonna move on to the negatives first. So we saw like that there was impact to people's physical health, because obviously they couldn't leave, they had to be at home. So not being able to do physical exercise sometimes, or not being motivated to do it as well. Mental health impacts as well, especially like emotionally, and just, you know, being able to continue studying or working sometimes. And there was one particular message from Aisha who said, you know, she couldn't hug her mum because she was worried that she could infect her, and she didn't know what the impact could be of hugging her own mum. So I think when we kind of got to talking about these subjects, it was quite just very insightful as to what younger residents are feeling, just in general. But we also spoke about loneliness and anxiety and stress that's coming from this. On a positive note, though, we saw people that said they had more time. So a lot of people started new hobbies. They didn't have to commute to work. And it was a chance for self-development and self-care, which I thought was fantastic, because people were suddenly saying, now I have to plan my day, and I can do a lot more things that I couldn't do before. People were able to connect in new ways, connect with their families differently. So it wasn't all negative, but it's just to say that this is some of the impacts that came up in our discussions with our younger residents. Can move to the next slide, please. And just in terms of our next steps, so we've got 2 projects. So for YAC, which is the young adults group, we want to continue to meet every 2 to 3 weeks. We're developing a social media and marketing plan. And obviously we can get all this information and we can create all these great graphics, but the main way that we can have an impact is by multiplying the reach and the message that we can get. And we're really trying to push this through social media. We're going to be doing some video messages as well, to be able to post on Facebook or YouTube, starting a new hashtag line. And then, yeah, we're doing some articles to put on the COVID-19 Merton newsletter. It's important for us that membership becomes inclusive, diverse, and accessible. And we're also going to be putting some of our information in. As I said, we're going to get this bank, this resource bank of information, so that even if people are joining a bit later, they can still have access to that information. Some of the stuff we've done is around the 2 different types of testing. So explaining the differences of the 2 testing, but the 2 tests available, but also the purposes of testing as well, which are quite important. I think what I mentioned before is that we had some people who joined our group because their parents are frontline workers. So I think they also begun to realize that actually testing is important, even though their parents are getting tested all the time. So, but in terms of the under 18s, I think that's going to be quite important when it comes to schools and schools reopening. I think, as you can imagine, a lot of the under 18s are not really going to know what's going on. I mean, they obviously understand that, you know, we're in lockdown, but they don't necessarily know the way that, you know, how testing is going to happen, how they're going to have to be able to go to school, how they're going to have to adhere to new rules. And it's also important to know the impact that it's having on them. So we definitely want to be connecting with schools as soon as we can. And then we're also going to be developing a social media marketing plan with them. So it's almost similar, but there is 2 young inspectors on each project. And that's because we want to kind of cater to specific needs. And if we're all doing the same thing, we can't really do that. And yeah, I think that's the main thing. And in terms of the under 18s, that collaboration with schools is really key. And I suppose just before I finish, I just wanted to say, if anybody here has any suggestions or any resource or any connections that they can help us with, we're more than happy to listen, more than happy to engage with you, because we obviously do want to grow and we do want to get that message across. Thank you.
Places like Merton.
Thank you, Martin. And really great work that that the young inspectors have been doing with the young community young COVID community champions. Just to talk about the ongoing engagement program a little bit before closing out, we are going to really emphasize more dialogue with the community, and I think we've got a great platform from which to do that. We have the Joint Consultative Committee of Ethnic Minorities, we've got the Faith and Belief Forum, we've got our patient engagement group, we've got the young adult COVID community champions, and the under 18 champions developing as well. And the feedback we get from those groups and this group and our engagement will help us to develop those clear messages that we need and get them to the right people. And we will continue, obviously, to build out those networks and work in partnership with public health and others within the community and voluntary sector to tackle health inequalities.
Thank you, Martin and Kaz. Really interesting insights there, but also I think a very timely presentation following our earlier discussion about the importance of accurate and accessible messaging. So it's great to see how those messages are already being tailored and how we're using different channels to engage and reach people. Does anyone have any questions for Martin or Kaz on how we can get involved, perhaps? Like Vasa?
Thank you, Martin and Kaz. It's really very useful information there. And the point about East European population, very well made. Personally, I've been trying to talk to my cleaner to try and get her to agree that she is high risk. And I remind her that she cleans our hot room, the very room where we as doctors go in and see 2 or 3 patients a day, but she has to then collectively clear up the viral load at the end of the evening. And I was trying to convince her. I convinced the husband, but I didn't convince her. So it's work in progress there. But this is really, really important to remember that they are at risk, and I'm not stigmatizing or generalizing, but you all know that certain ethnic groups are predominantly working in certain jobs. And I think we do a disservice if you forget that. And so keep up the good work with the East European communities, but there is more European countries than Poland. So we need to, it's not a criticism, it's only a comment, that we expand into the whole of Europe rather than retreat. Martin, intergenerational working. How do we make your youngsters, I call your generation, how do you get your generation to speak to granddad and convince him that the vaccine is really the beacon of hope for him?
Martin, did you want to come back on that? Yeah.
I think that's a really good point. I think one thing I always say about just engagement and young people is that young people are the bridge to their parents, and particularly because a lot of our younger residents, they speak 2 languages. Like I speak another language as well, and sometimes that is something that we kind of forget, but it's actually key to being able to reach just in general, like the older population as well. So maybe it is something that we can do, and I think it's something that I can ask people in terms of diversity. The group is actually quite diverse. We've got like people from Afro-Caribbean backgrounds. We've got people from Philippines. We've got people from I think the Tamil backgrounds as well. And so I think if that is something actually that the group is equipped to do and they were willing to do, that's something that I could probably bring up, because in terms of language, we've got more languages, I should say. We've probably got 4 or 5, maybe even 6, 7 languages. And so if that's a way that we could help and support, that is something that I could bring up with the team next time. And that's something maybe we could push. So I think that's a very good point. Thank you.
Thank you, Martin. Ellie, sorry, did you have a question?
Dagmar, can I come in on that question? You look like you were signalling.
Yeah, I wanted to for us as a group to really take that challenge from us. Our CCG colleagues laying out the vaccination plans, and they do cover comms and engagement, but I think there's enough known about vaccine hesitancy and the core in a way problems that the most vulnerable communities are often the most hesitant. So I think we've got an infrastructure with all you lot and your connections and our champions that we have been using for the protection messages, that we should really consider now how we make best use to tackle the vaccine hesitancy. And maybe when we plan for our next meeting, we might want to think that through a little bit more, we will probably have a bit more data so that we can target our efforts. But I just wanted to absolutely welcome Vasa, a new task in a way for this group going forward.
Thank you very much, Dagmar. Ellie, did you have a...
Just quickly, because I'm aware of time, but just thank everyone for their work in this engagement, but particularly Martin and the young inspectors for the work with the young people. And just to highlight one thing that we skirted over whilst talking about the asymptomatic testing is the testing in schools relies on consent of the parents. And for me, one of the advantages of this reaching out directly to young people might be to kind of increase those levels of consent, because that kind of rapid LFT testing is only going to work if large numbers of the population in the setting have it.
Thank you, Ellie. And yes, mindful of time, are there any final questions to Martin or Kaz on the engagement work? Okay. Thank you very much for your presentation. It was really, really helpful. And as Dagmar says, something that we will want to look at in more detail at the next meeting, I am sure. So thank you everyone for giving up your time this evening, and I'll give you the rest of your evening back. I look forward to seeing you next time. Thank you. Bye.
So how would we